Hello everyone, today we'll be discussing gastric cancer. Gastric cancer is the fifth most frequently diagnosed cancer and the third leading cause of cancer deaths worldwide. There are two distinct types of gastric adenocarcinoma, which is intestinal, which is well differentiated, and diffuse, which is undifferentiated, which have a distinct morphologic appearance, pathogenesis, and genetic profiles. The only potentially curative treatment approach for patients with gastric cancer is surgical resection with adequate lymphadenectomy. However, regrettably, patients with an unresectable, locally advanced or metastatic disease could solely be offered life-prolonging palliative therapy regimens. Anatomy. So the five layers of the stomach wall include the mucosa, submucosa, muscularis propria, subserosa, and the serosa. Etiology. So factors that are linked with an increased risk of gastric cancer include nutritional factors such as high salt and nitrous compounds consumption, smoking, low vitamin A and C diet, consuming large amounts of smoked or cured foods, a deficit of refrigerated foods, and contaminated drinking water. High BMI, increased calorie consumption, gastroesophageal reflux, and smoking are associated with an increased risk of adenocarcinomas of the distal esophagus and the proximal stomach. Then host factors include having a blood group A, pernicious anemia, which is an autoimmune chronic atrophic gastritis, then presence of benign gastric ulcers, hypertrophic gastropathy, and gastric polyps are risk factors that are associated with an increased risk of stomach cancer. Then 5 to 10% of cases have a family history of gastric cancer. Pathophysiology. So there are two main histologic variants of gastric adenocarcinoma that are based on Lawrence histopathologic classification. The most frequent is the intestinal type, that is so called because of its morphologic similarity to adenocarcinomas that arise in the intestinal tract. The less common diffuse type gastric cancer is characterized by a lack of intercellular adhesions, which disrupt the formation of glandular structure. Then clinical presentation. So the most common presenting symptoms for gastric cancers are non-specific weight loss, persistent abdominal pain, dysphagia, hematemesis, anorexia, nausea, early satiety, and dyspepsia. Patients that present with a locally advanced or metastatic disease usually present with significant abdominal pain, potential ascites, weight loss, fatigue, and have visceral metastasis on scans and can have a gastric outlet obstruction. Then the most common physical examination finding is a palpable abdominal mass that indicates advanced disease. Patient may also present with signs of metastatic lymphatic spread distribution that includes varicose nodes, which is left supraclavicular adenopathy, systemary Joseph nodule, which is a periumbilical nodule, and Irish node, which is left axillary node. Direct metastasis to the peritoneum can present as Krukenbeck's tumor, which is ovarian mass, Blummer's shelf, which is cul-de-sac mass, ascites, peritoneal carcinomatosis, and hepatomegaly, which is often diffuse disease burden. Then evaluation of patients with gastric CA. So patients presenting with any symptoms suspicious for gastric CA should undergo an upper endoscopy. Although upper endoscopy is more invasive and costly, it offers tissue diagnosis by direct biopsy of esophageal, gastric, or duodenal lesions. So basically what they're saying is upper GI endoscopy, even though we know it's more invasive, it gives you a chance to biopsy the lesion. So you won't just sit in case you see any mass, you can easily take the lesion for a biopsy and then send it for histopathology, which will give you a diagnosis. Then staging of gastric carcinoma. So they use the AJCC TNM staging system. So the staging system most often used for stomach cancer is the American Joint Committee on Cancer TNM system. This system is used to stage all stomach cancers, carcinomas, except those that are starting in the gastroesophageal junction or those that start in the cardia, which is the first part of the stomach, and are growing into the gastroesophageal junction. These cancers are staged and often treated like cancers of the esophagus. Other types of cancers that can start in the stomach, such as the gastrointestinal stromal tumor (GIST) and lymphoma, are staged differently as well. The TNM stage system for stomach cancer is based on three key pieces of information. So the T category describes the extent of the main primary tumor, including how far it has grown into the layers of the stomach wall and if it has reached nearby structures or organs. The N category describes any cancer spread to nearby lymph nodes. The M category describes any spread or metastasis to distant parts of the body, such as the liver or the lungs. The number of letters after T, N, and M provide more details about each of these factors. The higher the number means the cancer is more advanced. So T and M, T basically refers to tumor, N to nodes, and M for metastasis. So when we look at the T and M staging, so the primary tumor, Tx means the primary tumor cannot be assessed. T0, no evidence of primary tumor. TIS, that is high-grade dysplasia. T1, tumor invades the lamina propria, muscularis mucosa or submucosa. So when we talk about T1A, that is tumor invades the lamina propria or muscularis mucosa. T1B, tumor invades submucosa. T2, tumor invades muscularis propria. T3, tumor invades the adventitia. T4, tumor invades adjacent structures. So T4 is divided into A and B. T4A is where there is a resectable tumor invading pleura, pericardium or diaphragm. T4B, unresectable tumor invading other adjacent structures such as the aorta, vertebral body, trachea. Then N is for regional nodes, so N0 means no regional lymph nodes metastasis. N1, metastasis in 1 to 2 regional lymph nodes. N2 means metastasis in 3 to 6 regional lymph nodes. N3, metastasis in 7 or more regional lymph nodes. Distant mets, M0, no distant metastasis, and M1 means distant metastasis. So management of gastric carcinoma. So treatment modality for gastric cancer depends on accurate preoperative staging. So therapeutic approach can be endoscopic resection for superficial, limited mucosa disease which is less than T1B and N0, or upfront surgical resection with lymphadenectomy for less than T3 on NEN, neoadjuvant for greater than T2, adjuvant for greater than T1N1 or greater than T3N0, chemotherapy, radiation therapy, or combined with resectable lesions, or palliative systemic therapy for those with locally advanced, unresectable, or metastatic disease. So that is T4, NEN, or M1. Prognosis. So prognosis of gastric cancer correlates with the extent of the tumor and includes both nodal involvement and direct tumor extension beyond the gastric wall. Tumor grade may also provide some prognostic information. Over 50% of patients can achieve cure from localized distal gastric cancer, but early stage disease only accounts for between 10 and 20% of all cases diagnosed in the US. The remaining gastric cancer patients present with metastatic disease in either regional or distant sites. And the overall 5-year survival rate for these patients ranging from almost zero for patients with disseminated disease to nearly 50% for patients with distal resectable regional disease. Even apparent localized disease only shows a 5-year survival rate in patients with proximal gastric cancer of only 10 to 15%. While therapy for patients with disseminated gastric cancer may result in symptomatic palliation and some prolongation of life, extended remission remain uncommon. Complications. Gastric cancer can lead to loss of appetite and weight loss. Cancer in the stomach can lead to ascites, causing fluid buildup in the abdomen, leading to the patient feeling pressure on their abdomen and shortness of breath. Metastases are also a complication of advanced gastric cancer, and common sites for metastasis include the lungs, liver, or bones. Radiation therapy and chemotherapy can cause adverse effects for some patients. So that's all about gastric cancer. Thank you.